Welcome back to Save Your Thyroid with Jennifer Holcomb, the podcast where we explore the latest non-surgical innovations in thyroid nodule care. For decades, a bothersome thyroid nodule often meant surgery, a neck scar, and lifelong medication. But what if there was another way? Today, we're exploring a revolutionary non-surgical solution called Radio Frequency Ablation, or RFA. It's a procedure that can shrink nodules while preserving your thyroid, leaving no scar, and allowing for recovery in as little as 24 hours. To guide us through this game-changing technology, we're joined by a true pioneer, Dr. Mary Sebelik. She is a professor at Emory University School of Medicine and director of head and neck oncology at the Atlanta VA Medical Center. And she's been instrumental in making RFA a reality for patients there. Here's what you'll learn in today's episode. What radiofrequency ablation, RFA, is and how this scar-free procedure works. The key differences between RFA and traditional thyroid surgery, from recovery time to the risk of lifelong medication. How a surgeon's unique background in ultrasound and global health created the perfect foundation for championing this new technology. Why the rise of RFA is being called a wake-up call for surgeons, and how it's changing the patient-doctor conversation, the future of thyroid care, and what's on the horizon for treating nodules without surgery. Now, let's dive in. Dr. Sebelik, welcome to the podcast.
I'm just delighted to be and honored to be here. Thank you so much, Jen, for the invitation.
I have really been excited to talk with you because I learned so much about you as I was preparing for this episode, and you have a very multifaceted career as a surgeon and a professor and a national leader in ultrasound, which we are going to dive into later, and a passionate global health advocate. You've got I'm sure, some really interesting stories in that front. Can you walk us through the journey of all of these, how they came together, and how that led to you being where we are today?
Well, thank you. Actually, I don't come from a medical family, but my mom was a huge reader, and she gave me books to read about heroic physicians and surgeons. And I read a book called Surgeon on Safari. And I think I entered medical school with this really idealism that I don't think I've ever lost sight of. I love the head and neck anatomy. So the thyroid gland is my favorite gland within the head and neck. So it truly has, being a thyroid surgeon has truly allowed me to pursue all of my interests no matter where I am. I became very interested in the tragedy of endemic goiters and how people live in low resource countries with gigantic thyroid enlargement that can really make them suffer. Mm-hmm. So my global health was able to utilize my thyroid surgery skills. And then as an offshoot of that, now at least 15 plus years ago, I brought ultrasound into my practice because you can't be a good thyroid surgeon without being a good ultrasonographer. So it does seem like all of my interests and career are all centered on the thyroid, and I'm able to use my knowledge of thyroid disease and surgery to allow me to move through these spheres.
Wow. Let's talk specifically about thyroid ultrasound then, because it is very, I would say it's not uncommon, but maybe it's less common for thyroid surgeons to do ultrasound, or maybe you can correct me if I'm wrong on that point. But you were an early and very vocal champion of thyroid surgeons doing ultrasound long before it was commonplace. What did you see in that technology early on, and how did that expertise that you held in that area pave the way for you to embrace a procedure like RFA?
That's such a good question. And I feel like we haven't made many strides in all the years that I've been teaching, but the surgeons who do bring ultrasound in their practice, it's like the light bulb comes on. You can suddenly see the anatomy before you make an incision. You can see where everything is. You can look for things that keep you out of trouble. I think I brought ultrasound into my practice in 2007, and I honestly don't know. I can't remember what I did before then. I mean, it just is such a natural offshoot of fingers. In fact, that's one of the things I call it, is it's the stethoscope for my fingers. I'm able to see under the skin what's there. And that really helps diagnostics, helps troubleshooting, helps communicating with patients. And anything that allows you to see under the skin and allows you to do procedures, such as procedures that might incorporate a needle, It's absolutely ideal to use an ultrasound to pass an instrument such as a needle under the skin. It's so funny. Jen, thank you for the questions you sent me, because I remembered attending the World Congress on Thyroid Cancer in 2013 in Canada. And there was an instructional panel on thermal ablation for thyroid masses. And the auditorium was absolutely standing room only. There were so many clinicians from around the world eager to learn about those exciting alternatives to traditional surgical treatment. And by then, I'd already been using ultrasound in my office for, I think, 8 years. And so 6 years. So fast forward to late 2018 in the United States. That's how long it took to get device approval for radio frequency ablation, which was the first thermal technology. And from that point on, all of my efforts for ultrasound teaching took on a whole new meaning and actually urgency. It's one thing to teach somebody how to look at anatomy, but it's much more critical to teach someone how to place a needle precisely and safely so that whatever they need to do to that patient's pathology, they know exactly where they are. Especially in the realm of thermal ablation, needle placement is central to the safety and efficacy of that procedure.
Absolutely. I would love to hear more of your experience with teaching in ultrasound, because actually, as a layperson, find ultrasound to be very fascinating and also very confusing, because sometimes just about the time when I think I'm starting to get it, then I realize how little I really understand it. And so if you want to give us like a quick overview of kind of how difficult is it for surgeons and endocrinologists who've not adopted this technology in their practice to really bring it into their practice, and why is it important that they do that if they're not doing procedures like RFA, because it is such a visual diagnostic tool.
It's funny, I'm smiling because when I was in medical school, we used to call ultrasound ultra smoke because you couldn't see anything. And so I do think that in the last 15 to 20 years, the machines have gotten so much better so that truly when you look at an ultrasound image, it looks like other kinds of radiology imaging that hopefully surgeons and endocrinologists are already used to looking at. It really does look like a CAT scan. Mm-hmm. So if you have sort of basic anatomy knowledge that you learned in med school and then went on to look at other imaging studies, it does allow you to learn ultrasound pretty well. But to answer your question, I think ultrasound is really about pattern recognition. So I like to teach ultrasound to anybody, whether it's my patient or office staff or another physician. I say, look, that's Mickey Mouse, or that's a snake, or that's a string of black pearls. Like, I really try to bring pattern recognition into ultrasound education, because that's really what it is. It's not, it doesn't have to be as complicated as an anatomy book. It really is just repetitively looking at patterns that become easy to recognize the more you look. I like to make ultrasound fun and look for fun things.
Wow, that is such a great explanation of it. I don't think I've ever heard it put that way before, but I think that making it fun is definitely better than having it be overwhelming and like just a bunch of gray blobs.
Yeah, because it looks like that, doesn't it?
Yeah, it does. And, even after being immersed in this for 6 years, obviously as a lay person, I haven't taken any medical training, but, I feel like I understand it a little better than I did before. And of course, I've been to 6 years of RFA follow-ups because I myself am an RFA patient. And so, I've seen lots of images of my thyroid, and I think I'm finally to the point where I recognize, okay, there's the lobes and there's the trachea. But then if it's anything other than that off to the sides, I'm kind of lost. So thank you for that explanation. That's really cool. So now let's talk about, you had some worldwide experiences in your medical career, over 2 decades working in places like Rwanda and Ethiopia, and co-authoring clinical guidelines in thyroid care in limited resource settings, like you touched on a moment ago, which those patients are the ones we see pictures of who look like they have 2 heads because they have these massive goiters. And as you said, their quality of life must just be very, very low. How has that experience needing to find effective and safe but resource appropriate solutions for these patients in these third world countries shaped your view on innovations like RFA here in the US?
Wow, thank you so much for asking me that. And this is where RFA, this could be like a perfect, the perfect combination of technology, knowledge, and realism. In third world countries and lower resource countries, access to safe surgical care is in a critical shortage, not just because there aren't enough surgeons, but there aren't enough anesthesiologists and hospitals that can take care of thyroid surgery patients, and lab work and imaging. So it's not just the surgeon, it's the whole system. And what if the many patients who suffer from goiter, who would never be able to either see a surgeon because there isn't one, or maybe can't afford to see a surgeon, what if they could have non-surgical treatment? I have a young colleague in Rwanda who has a long waiting list of goiter patients waiting for surgical dates, but many of those will never even be able to afford surgery.
Mm.
So it's funny, I gave a talk in South Africa in December asking exactly this question. What if we could bring RFA to low income, low resource settings that didn't have surgeons or didn't have the infrastructure for surgery? And since December, I have met so many surgeons at home and abroad who are so excited by this possibility. Two of my best friends and colleagues in Manila in the Philippines have been teaching and performing RFA since 2020. And so they're bringing it in a medium to low resource setting as a very almost game-changing technology to avoid surgery for the patients. And I actually just met a new thyroid surgeon friend from Stellenbosch University in South Africa who is looking for funding, and we're going to start a project because she has so many goiter patients who very realistically wouldn't have to have surgery because of this technology.
Wow.
I will say during the time period in the United States where we didn't have insurance coverage, it kind of felt the same way here in the US, where the people who did have money for paying out of pocket were able to get the procedure, but somebody else who doesn't have as much income was not able to get the procedure. And I really felt badly about that the income disparity also applies here in the United States. So now that there is insurance coverage, I'm so much more relieved that we can really offer this technology to anyone suffering from symptomatic thyroid nodules.
Absolutely. I get messages from people all over the world asking me, is there a RFA physician in my country? And would you believe I get a lot of them from the Philippines and from South Africa?
Well, maybe we can change that.
That would be incredible if I could point them to a clinic in their area. I also get some from like the northern part of the African continent as well. But I imagine there's always more in South Africa, and I would imagine it's because they have greater access to internet in more major cities in South Africa. Yes, I was thrilled when I found out that microwave ablation had become available in the Philippines. I think it's always good for patients to have multiple options. Not every patient is an ideal candidate for just one particular technology. So I think it's incredible to be able to say that now we have 7 different technologies available in the United States. And, that's the whole point of our website, saveyourthyroid.org, to help educate patients on those technologies. So, now let's compare RFA and surgery, because that's often the question we get from new patients in the Save Your Thyroid community is, what's the difference? What are the risks and the benefits and the advantages and the disadvantages? So obviously for decades, when patients didn't have access to non-surgical techniques, they would have surgery. And now you're a leader offering radio frequency. So what was the aha moment for you when you realized this was the game changer? Because, but one of my favorite questions for surgeons is, okay, you're a surgeon, you're doing surgery. What brought you to non-surgical modalities?
So I love this question. So I will answer the aha moment first. I still thought of RFA or any thermal ablation is kind of magic. Like it's magical, right? I can't see it happening immediately. And most surgeons are kind of trained to look for immediate gratification or immediate
Right.
results. And so my aha moment was the first patient who came back to see me, and we did some volume measurements, and he was saying, it's a lot smaller. And I'm saying, I don't know. And I actually did the math, and it was like 75% reduced. So I going, it actually does work. This is kind of, so it's not just magic. It actually works. I'm a thyroid surgeon, so it's my tool. But I also, it's deeply ingrained in me that I never ever want to do something unnecessarily. So doing unnecessary surgery is not something I can do. And to have an alternative so that these surgeries for benign disease can become unnecessary is very powerful.
Absolutely. Absolutely. I actually would love to see data on how many fewer thyroid surgeries are being done now that we have non-surgical techniques, because the statistic that always stands out in my mind from about 6 years ago, that actually my doctor gave me the statistic, was that 150,000 thyroidectomies are done annually in the US, and that 50,000 of those, if I'm getting this right, it's either 100,000 or 50,000, which one is it, are benign. Do you know off the top of your head? I think it was.
Well, and that is that those numbers aren't far off, because most thyroid pathology is benign.
Mm-hmm.
And I actually have a young and very research energetic fellow right now who's looking at that question and looking within outpatient. How can even in that narrow sphere, can an outpatient procedure in the office ultimately reduce the number of outpatient surgeries, thyroid surgeries? So that is something that should be looked at, because it's not one-on-one. I think initially my institution wanted to price RFA to represent the money they thought they were losing by not doing the surgery, but that isn't accurate. Patients who don't want surgery don't want surgery. So just because they can't get RFA doesn't mean they're going to go right to surgery. I think it's a false equivalence. And so that's where it complicates it, because I think more people can get their disease treated who otherwise would never have had surgery. So I'll come back to you with that, because I think that's a fascinating and very important question to answer for the healthcare system.
Totally.
But I think it's going to be a very quick change.
Yes. I remember now that it was 2/3, 100,000 of the 150,000, 2/3 of them were for benign disease. And so when I think about 100,000 patients losing half or all of their thyroid for a benign thyroid nodule, like, that just makes me so sad. Because let me just pause for a moment and share my own personal experience for context here. So
thank you.
I had RFA done on 2 different occasions because I had a very large nodule on the right lobe of my thyroid. It was benign. 20% of it was substernal. And I was very adamant that I did not want surgery because I was concerned that I would not do well on thyroid medication for the long term. I have a history of allergic reactions and intolerances to drugs. So fast forward to about 1.5 years ago, I actually began, a few months before that, going into perimenopause. And as I went into
Hate that.
transition, yeah, it's not a fun transition, but part of that transition, I started to see my thyroid function declining. So I had a difficult time functioning, and I decided I needed supplemental thyroid medicine to be able to live in my best quality of life. Well, after about 9 months on that medicine, I had an allergic reaction to it. And long story short, I won't go into the whole story about the allergic reactions in the process of recovery. I'm now on a compounded version and I'm doing great. But just that tiny little dose of medicine that I have makes such a difference in my ability to live my life and feel well and function well. I can't imagine what it would be like if I was having to take a full replacement dose. And for the patients out there who lose their thyroid because they have a benign nodule and then end up on a full replacement dose when they don't have cancer, so or Graves' disease or something that's like very, obviously a surgical case. So that experience that I had literally just in the last month with my allergic reactions, it's made me that much more grateful to have a mostly functioning thyroid, because I feel like topping off the glass, is so much better than having to, for me personally, I'm grateful that I don't have to fill the glass up from the bottom, that it's just topping it up. I apologize for digressing there, but I wanted to share that because I feel like you understanding the importance, the game-changing aspect of a non-surgical tool, I think it just brings that idea to the front of a surgeon's mind, and patients love to see that because they always tend to think that surgeons just want to do surgery.
Well, and we enjoy it, but like I said earlier, I really only enjoy it if it's absolutely a necessary thing to do.
I'd like to take a moment to thank the sponsor of today's episode, RGS Healthcare. RGS Healthcare has been a leading medical imaging equipment distributor for more than a decade. RGS is known not only for recommending personalized medical equipment solutions, but also for offering continuous support to ensure success. One thing RGS is particularly known for is unparalleled physician training and on-site staff support. They are the only medical equipment supplier known for accompanying their doctors to exclusive, specialized thyroid RFA physician training on live patients proctored by leading world experts. If you'd like to learn more about RGS Healthcare, please visit their website, rgshealthcare.com. A heartfelt thank you goes out to RGS Healthcare for supporting this channel. Now, back to the podcast.
Thank you for sharing your story. And you really bring up an important change that also is happening and needs to happen more. I think for decades, physicians have been very paternalistic about thyroid hormone replacement. They go, oh, your TSH is normal. You can't possibly have symptoms. You should be feeling normal. And that paternalism, or that sort of hierarchical approach to it and dismissing the patient's feelings, just needs to go away. It is, and how I explain it to my patients, and you already know this, is that even though it's the same organic chemical that you might be taking in a pill, it is not from your native tissues. And there's so much about levothyroxine and T3 and T4 and cytomel. There's so much we don't know about what the precise mix that an individual patient needs. So we have to stop being paternalistic about that and stop dismissing patients' observations. That is something I've seen over the years, that patients feel better when it's their own hormone. 100%.
Yeah. Well, I love that. Thank you for sharing that. And, I think that I have a patient review that praised you for offering this different option to surgery. So obviously you're listening to your patients. When a patient comes to you with a benign nodule, how do you frame that choice between traditional surgery and RFA? And what are the trade-offs that you discuss with them, making the right decision for their particular situation?
I really give my patients a Ben Franklin list. I think my mom told me how to do that, where you list both options with the pros and cons. And when you really go a direct comparison between the two, it becomes very easy to see that the only pro on the surgery side is that the patient wakes up in the recovery room without the nodule. There's no waiting. So that could be construed as a positive thing. But after that, all the pros are on the RFA side or on the thermal ablation side. There's no recovery time, no scar, faster, safer, no loss of thyroid function. It just takes longer for the nodule to shrink. And patients who wish to avoid surgery have patience. They're very motivated. And they're very motivated to do the waiting. I find that it's me as a surgeon, I've had to learn patience. I've had to learn not to expect the nodule to go away immediately. And that's been pretty easy. But my first foray into this, I had to learn patience myself, because the patients, excuse the pun, the patients already had they already were looking forward to a gradual reduction in size.
Mm-hmm.
So that's what I do. I just compare them head to head with patients.
Mm-hmm. And I love that, that concept of a surgeon being okay with that, degree of uncertainty where it's like, this nodule's not going to completely disappear or go away. For patients watching this podcast, RFA will shrink the nodule, but it won't completely go away. In my case, I still have a 6cc little tiny nodule in here, and I can't feel it. I can't see it. I had a doctor's appointment literally a week and a half ago, I think. My doctor, palpated my neck. She was like, nope, feel no nodules here. I have nodules on both sides, but they're all very small and they don't cause me any symptoms. The patients, most of the time, they understand that concept of that it's going to take time. Sometimes new patients come to the community and they say, well, I had my RFA and then why is my nodule still here? And we explain to them, well, it is a gradual process. The immune system has to break down that dead tissue now. And so one of the most exciting posts we see is a patient has their 3-month follow-up visit and they find out that their nodule shrunk by 50, 60, 70, 80%. And that they're no longer choking. I had a patient just the other day tell me, I'm no longer choking on water.
That's great.
So it is life-changing. I know for me personally, it was life-changing because I was to the point where I was just choking all the time. I was in misery. And so it was definitely a life-changing thing. And I'm so grateful that surgeons are adopting this non-surgical technique. So let's talk about how you brought this technique to Emory, specifically Emory's Winship Cancer Institute in the Atlanta VA. And the VA is definitely a population that needs access to RFA. We've seen only a few VAs in the US adopting this. And so what are the unique challenges and rewards of implementing this technology in these on one side, a premier academic center, and on the other side, a public health system like the VA?
Well, and it actually turned out to be that each pretty disparate healthcare system had their own assets. I took my RFA training in February of 2020 in Brazil. I went to Rio de Janeiro with all the grandfathers, the fathers and mothers of RFA training. And I came home to Atlanta so excited. And what happened in March of 2020?
Right.
Everything shut down, not only in our ability to offer care for many patients, but also just in our ability to develop programs, buy equipment. Right. So ironically, Emory, as a wonderful premier academic center, was unable to focus on that during that challenging healthcare time. Mm-hmm. But the VA, their budget kind of continues. And so it also is not a fee-for-service environment. So the patients who served our country and get their care at the VA were able to get RFA. It kind of a miracle. We got an RFA machine and the needles, and we were able to start a program at the VA because the healthcare system is structured differently. So then it took Emory and our cancer center longer. It is a little bit ironic. I do work in a cancer center, and this is for benign disease, but our clinic is a little bit off to the side from from the cancer patients. So every once in a while, I'll hear a new patient say, do I have cancer? It's like, no, you have benign disease. You're just seeing me in a cancer center. But it took time for the academic center to understand how to offer it, how to finance it, how to make it fit into our care pathways. Mm-hmm. So ironically, the VA was a lot easier. And if you happen to be a veteran with benign thyroid nodules, you were able to access that care.
That is excellent. I actually have heard from many veterans looking for RFA. Just as a question about access, does a veteran need to live in the Atlanta area to access care at the Atlanta VA, or is it a national kind of system?
That's a great question. And I think one of the things we don't always do so well within the VA is communication. But what exists within the VA system nationally is if the patient is a good candidate for a specific kind of care or service that their home VA doesn't offer, the VA does offer either interfacility referrals to another VA, or they offer community care referrals to somebody in the community, and then it's VA finance. That's been part of a lot of the changes for improving veteran healthcare access.
Wow.
So even if their home VA doesn't have it, they have those two options for accessing care, either to another VA that has it or to the community.
That is excellent news. I'm so glad to know that. And I'm sure that there are many veterans out there who will be glad to know that too, because at this time, not even just veterans, but all patients across the country and across the globe oftentimes are traveling still, even now 6 years after FDA clearance of RFA in the US, are still traveling to access treatment. So did you have a comment on that?
I did. I think because Atlanta is huge. And I think per capita, we don't have as many RFA practitioners as you might expect. But that's just an aside.
Yeah, I mean, you're right. I mean, Atlanta is like a major international hub. You know, you can't go anywhere hardly without going through Atlanta. I know where I live in Huntsville, Alabama, almost every flight goes through Atlanta. Yeah. And so, you know, you would think that it would be more of a magnet for that sort of technology, but we're still seeing growth, and we're moving in the right direction. You know, our community website, saveyourthyroid.org, we maintain a list of physicians who offer all of the different non-surgical techniques. And the last time I checked, I want to say there was about 180 different names on that list. When I had my first procedure, before I created the website, we only knew of 2 in the US, and that was in 2019. So we've come a long way.
We have come a long way, and it's wow. And it has been slow. You're right. But I think it's going to accelerate tremendously this year in 25.
I agree too. Yes. And you mentioned a moment ago about insurance. And so can we talk about that for a little while? I would be curious to hear about your experience with that. I know you're in an academic setting, and so, you know, it's different in every different type of setting, whether private practice, academic. What has the response been with patients coming for treatment now that we do have, as of January of 2025, a CPT billing code? Have you seen more patients? Have you seen a lot of insurance companies, you know, paying for these procedures? How's that been?
So that has been, that's actually been great. And I like to remind patients, I'm salaried. I don't care whether they have insurance or not. That's not in any way what motivates me to provide care. But I do care very much that patients aren't bankrupted by medical bills.
Yes.
And so prior to having a billing code, although there was some change, there was some slow change, the vast majority of people offering RFA by necessity charged cash for it. And then the patient was often put in a position to try to go on the back end to get reimbursement from their insurance company. And so I was part of the process of getting CMS, federal agency, to create the billing code. I mean, I wasn't integral to that, but I was on the review. I reviewed some of the documents that CMS put out, and the process to getting the code for a new technology or new procedure is kind of cumbersome, and it's unpredictable. This one took 5 years to get a code, and that's much longer than, I don't know, in my part of the specialty, new sinus procedures seem to get codes really quickly. The process was so long. And then what happens when CMS creates a newly approved code, right from the beginning, January 1st, Medicare covers it. And then the way our healthcare financing works in the United States is commercial insurance providers follow behind Medicare. And so very quickly it became covered. And like many physician practices, our practice submits the code for pre-approval, and the patient already knows going in that insurance is covering it. I did actually have a long list, growing list of people. I said, you know what, can you just wait till January 1st? That way I don't have to worry about you having to come up with cash.
Yeah.
Because I just thought that was unfair.
Wow, that's so thoughtful of you as a physician to consider that. And when I had my procedures, I didn't know if my insurance was going to cover or not, because the institution where I had my treatments had a policy where if you had insurance, they had to bill your insurance, and if the insurance did not pay, then you had to pay the full amount which was billed to insurance, which for me would have been $30,000 each time. So I went into both of these procedures not knowing if they were going to be covered. And the only thing I can say made it be paid for by my insurance was a miracle. Thank God it was covered by insurance and it didn't bankrupt me and my family. I'm so grateful for that. But not everyone is that fortunate, or was that fortunate prior to the enacting of this code. So I'm very glad we do have a code now. We do still see patients that don't have success with insurance coverage yet. I think maybe we're still in the process of, insurance companies rewriting their policies and reimbursement amounts. I'm not an expert on that topic, but I would just say patients that are in that limbo period still, that you're still getting feedback saying that it's not covered, even though we do have a code. I think that things are going to shake out eventually. We're just maybe still in a transitional period. What do you think about that?
I do. I do think that it's going to be faster than slower. I mean, even as recently as last year, I'm not going to say the company, but even as recently as last year, the thermal ablation or radio frequency ablation for thyroid in the insurance document of coverage was still considered experimental. Mm-hmm. And so thus would not be covered. And so I think it's those individual payers that have to review the literature. And
exactly.
And really what makes insurance providers change often is pressure from the patients and their employers who provide the insurance.
Yeah.
So it really takes patient advocacy, which is you're such a critical part of. It takes patients to push back. And that will also hasten the speed at which some of these policies change.
We tell patients all the time, if you get a denial, you can always appeal it, and you can appeal it a lot. Mm-hmm. And we often say, the little phrase, the squeaky wheel gets the grease. And so we've seen patients who have appealed 2, 3, 4 times and finally gotten theirs covered. So we try to help patients through that process. We do have a template of an appeal letter actually in our Facebook community, which was written by one of our patients and has been modified by thousands of patients in our community over and over and over again. So I hope for the insurance reviewers who are seeing these letters that they're reading all of these studies that you mentioned, that we have mountains of data on the safety and efficacy of this. And, considering the cost savings alone, you would think that insurance companies would be in favor of saving money.
You'd think so. Yeah, you'd think so.
So, okay, well, we've talked about benign nodules. Now let's talk about the idea of considering small, low-risk thyroid cancers. Where do you see the use of RFA for that going in the next 5 to 10 years? What's the next frontier in minimally invasive treatment of thyroid disease?
So I think using ultrasound-guided interventions for thyroid cancer really fall into two broadly far apart categories. One is exactly what you asked about, somebody who has a low risk and very small thyroid cancer. And just the knowledge that you have cancer, even if it's very small and very low risk, that is a hit to your quality of life. You think about it. You can't sleep. You think about your kids. You think about what your future is going to look like. So there's tremendous value in having a method to treat even the lowest risk cancers. On the other end of the spectrum, maybe the unfortunate individual who had a pretty difficult thyroid cancer and they've had multiple surgeries and they either are exhausted or they can't medically or surgically tolerate another surgery. I do alcohol ablation, which is a little bit different, for residual disease in the neck as an alternative to a high risk surgery. So those are really two ends of the spectrum. What we're concentrating on now, I think globally and in the US, is those patients with low risk thyroid cancers. not clearly offering that right now because I think in the US, our data collection is in its infancy. And I think it has to be done really carefully. You have to have very good surveillance afterward. And what many of my colleagues who've started their programs, they do a biopsy 1 year after RFA to prove that there aren't any leftover cancer cells. And I think it has to be done really carefully, probably at the more experienced centers. I don't think it's ready to be done out in the community as yet, but should get there pretty quickly.
Excellent. Well, and I think that you're right, that being very, very cautious and careful in terms of the patient selection and the monitoring after the procedure is done. One of the statements I remember early on when I've kind of dove into this area about thyroid cancer being treated with thermal ablation was, if you treat a thyroid cancer that looks like it's been ablated with ablation, then how can you tell what you've done? Because for those of you watching this who don't know what I mean, when you look at a thyroid nodule on ultrasound and it is suspicious or it is cancerous, they typically look very different than a benign thyroid nodule. They're irregular, they're dark, the borders are, misshapen. What happens to thyroid nodules after you ablate them? They develop those very characteristics as a normal part of the process of treatment. And so I remember I was in a panel discussion once and I said, so how do you tell the difference? And the leader of the discussion said, that's a great question. I'll get back to you on that. So I do think it's important that we tread lightly and carefully here and not be careless, because we don't want to be unnecessarily putting patients at risk when we don't know exactly, how things appear differently at that point. Do you have any thoughts on that?
I think in its infancy in the US, and as an aside, treatment of low risk cancers with RFA has been performed safely and well in other parts of the world, particularly in Korea and other Europe and other centers. Here in its infancy in the US, I think having the person doing the ablation and having that person 6 months to 12 months later do a confirmatory biopsy, but have it be the same practitioner is probably a really safe way to get started. And then from there, I almost feel like a patient could wear a medical alert bracelet that says, I've had RFA, my thyroid's going to look different.
I think that's brilliant.
And even snapping a cell phone picture of what your nodule looks like in surveillance, if you do have to change doctors or move to a different part of the country, take it with you and be really in partnership with your new doctors that your thyroid will look a little different.
You're exactly right. That is actually a common issue. We see patients struggle with the lack of understanding between different physicians, when they move, when they change insurance, or if they just had their treatment done in a different state or country from where they live, and then they're trying to follow up locally. One of the common issues I've run into actually recently, I started doing patient consults where I try to help patients navigate this very unusual treatment path that they could be trying to navigate. So patients come to me and they say, well, I've had an ultrasound at this hospital and I've had another ultrasound at this hospital, and they'll send me 3 different ultrasounds and they'll have 3 completely different diagnoses, and they're confused and they don't know. One patient recently, actually in the last week, literally had completely wrong diagnosis, which I didn't know that it was the wrong diagnosis, but I suspected that it was. And I said, I think you should go to someone highly trained in ultrasound. And here I am talking to someone highly trained in ultrasound. I said to her, you need to go to someone who has been highly trained in ultrasound, because I think that she went to the emergency room. I said, the emergency room is a great place to go if you think you're dying, but I don't know that they're necessarily the best place to get diagnosed by someone who needs to know everything about what they're looking at and in your neck and the anatomy and the idiosyncrasies of thyroid specifically. They said part of her nodule was extending out of the thyroid. Well, when she went to see the highly trained ultrasound expert, her nodule was not protruding out of the thyroid. Her nodule was not high risk. Her nodule was actually benign and very low risk. And it was just there. It was not dangerous and not an emergency at all. And so she went from thinking one end of the spectrum to the other, all because of imaging. And so coming back to your experience with imaging, I think it's so vitally important for patients to understand that not just for the diagnosis, but even for the follow-up, the imaging is critically important. And I don't know if you want to add anything to that with your, decades of experience doing ultrasound, but I would love to hear your thoughts.
I will give you a short thought, and with a shameless plug for my son. He's a biomedical engineering student, and his interest is imaging, artificial intelligence, and machine learning. And already there are programs, software to machine learn thyroid nodules. And that doesn't mean that radiologists and doctors and people looking at ultrasounds are going to be replaced.
No,
it means that we're going to get much more accurate assessments of these nodules. I see it all the time. My team, we see it all the time, where somebody will come in very scared because they've been told they have a very high risk looking nodule, and it's a cyst, which we know is a almost never cancer situation. And that there is so much human variability between interpretation of thyroid nodule appearance. And so that's actually a really good place for machine learning. Again, not putting a plug in for my engineer student son, but that's one of his interests.
Oh, I'm very excited to learn more about that, because I think, AI has such a lot of people think AI, they kind of give it a bad rap. And I don't think that it's reasonable to consider, like you said, that it would replace physicians, but that, it would be this incredibly helpful tool, because as a human being, you can't possibly know everything, at all at once, but this AI can. And so you could use it as a tool, not as a replacement. So I'm really glad that you mentioned that about your son. That's very cool. Hey, just a quick break to share something I'm really excited about. My brand new website, saveyourthyroidwithjen.com. You can head there to subscribe to my mailing list and stay in the loop about new podcast episodes, videos, and updates in the world of thyroid nodule care. And I'm now offering something new, one-on-one patient navigation services. If you're feeling overwhelmed or unsure about your treatment options, I'm here to help. As a patient who's been through this myself and spent years learning from some of the world's leading experts in thyroid nodule treatment, I can help you make sense of your choices and feel more confident in your next steps. You can learn more about patient navigation and everything else I'm working on at saveyourthyroidwithjen.com. Now back to the conversation.
I have been very impressed by your patient advocacy, because I've seen that you've been at some of the big national thyroid meetings. Clearly you're an expert in this. You go to big medical meetings, and who's the constituent not there? Patients.
Yeah.
Patients and their advocates are not at these big scientific meetings. Why is that? So the fact that you have created this patient advocacy that's truly in partnership with the medical community is amazing. I just want to get that in there. I think that's so cool.
I appreciate you saying that. That means a lot to me. It has been difficult, actually. I'm going to ATA again this year. I didn't get to go last year. As a layperson with no degree, I don't have letters after my name. I have a bachelor's degree, but it's not anything relevant to this. I don't have an in with these big meetings unless I am invited by someone, or in this case, going to ATA. Save Your Thyroid, my organization that I founded, is fiscally sponsored by THYCA. And so because of that relationship, I can go as one of their support staff. I sit at the table and put my little SYT cards out for doctors to pick up and give to their patients. And they have these, I don't know if it'll focus, but they have these QR codes on the back, so that you're having a patient consult and the patient's terrified because they have a thyroid nodule and they don't know anything about what to expect. They forget everything after the appointment, but you can say, when you get home and you have time to think about it, here's a Facebook group for patients. You can go join this group. And so I do that at the ATA meeting, and I try to connect with all of these different doctors and companies and just, try to get in front of them. And, it's been really, really interesting, because I don't know why willing to talk to me and give me the time of day. I'm not an industry. I'm not a big production company. I'm literally a one-woman show here. I do all of the work myself on this podcast. And so, I really appreciate that they will listen to me and talk with me and give credit to what I do. What we've done with the Save Your Thyroid community. It has not been easy. It is definitely, and it's also like you said about the patients are not represented at ATA. You're exactly right. As I was trying to become a member of ATA, they don't even have an option for patients to join or patient advocates to join. It's like you have to provide all this documentation and credentials, and I don't have any of that. So I think that's really
I hope that changes. That's and my overall subspecialty is head and neck oncology. And so that's such a special group of people that need all the support they can get. And they should absolutely have partnerships with their medical team.
Circling back now to, we have just a couple more points. So your patients consistently describe you as an incredibly compassionate person, someone who truly listens to them, which is something that patients tell me is kind of their biggest frustration, is not feeling heard or listened to. So in this era of ever advancing technology, how do you balance the high tech, as we've been talking about all of these incredible technologies, with the high touch in your practice, listening to your patients?
Thank you for asking that. I came up with this idea probably 5+ longer ago. I've had this idea for a long time. So thank goodness to Emory, they allowed me to do this. I engage patients visually in their ultrasound experience. I have, in each of my exam rooms, I have a monitor on the ceiling. And in part, that's the most important reason for that, is so patients can be very engaged in their surveillance, in their diagnostic process, in their procedures, but also self-serving for me. It helps keep them comfortably on their back and looking up so that I have more access to ultrasounding their neck. And very, very rarely a patient might say, oh, I can't look, I'm going to keep my eyes closed, but that's almost never the case. And I also invite family members to be in the exam room and in the procedure room, where they can watch a procedure being done on their loved one on a big screen on the wall. And I think this is like, why don't more people do this? It's such a visual science that's how we bring high tech in to this ongoing conversation I'm having with them about what their thyroid looks like and what it could be and how we can treat it. It just is bringing, big screen monitors to making my relationship and my rapport with the patient very immediate.
I love that. And I think that is so critically important to lowering the patient's anxiety too, because, one thing I really despise is when I go for an ultrasound exam and I feel like I can't see the screen, I can't ask questions, I'm not allowed to know what the results are. It's like it's not going to be divulged to me until the radiologist interprets it. And I'm very curious. I would love to see the ultrasound screen and see what they're noting and what they're, where things have gone in the last 6 years. And so I think that's fantastic that you have a monitor on the ceiling. And as you said, it serves two purposes. It's helping you and it's helping the patient. And then that you're bringing in the families as well, I think is incredibly just very helpful, because what do families have knowledge about? They have knowledge about surgery most of the time. And so when a patient goes to their family and says, I don't want to have surgery, even though that's been recommended, I want to do something different, we see patients frequently say, my family thinks I'm crazy. My family thinks I'm being irresponsible. And so bringing the family in so that they can fully support the patient through this journey is incredibly helpful. I was just doing a consult with a patient earlier this week where, I was talking with the man and I said, how does your wife feel about this? I said, because I think you and your wife need to be on the same page about this. There's nothing worse than being on opposite sides of what you feel is the best treatment for you. And so, I think that's wonderful that you do that. Thank you for sharing that. And then our last point that I really want to talk about is that in a video for Emory, you mentioned that recent scientific advances have given a very real hope to some patients who historically had no chance. And that is very meaningful to you. What about this work continues to energize and inspire you every day? Obviously, you're very energized and inspired. I can tell just through the things you've been telling me today. So Tell me about that.
Thank you for asking. That video that I made is really, there's so much research and new medications that are being used to treat some of the most uncommon but very aggressive thyroid cancers. So this is the other end of the spectrum. Cancers that are called anaplastic thyroid cancer and poorly differentiated thyroid cancer. I can't tell you in my career how many times I've had to have end-of-life discussions with patients facing a very aggressive thyroid cancer.
Wow.
Now, to remind your viewers, those are very uncommon. We're a tertiary referral center at Winship, so we see them because they get referred to a bigger cancer center. But the advances in treatment for that have been a game changer, where there is real hope for that population of patients to get through their very difficult cancer. And really at exactly the same time, but unrelated, the RFA movement has happened. So for the patient on the other end of the spectrum who has a benign disease that's making their life miserable, we also have this really game-changing technology. And in a sense, there are two parallel tracks. We are so fortunate where we are in science right now for thyroid disease that two very different populations of patients, but hope for both. And such an exciting time to be a thyroidologist and to be able to offer these more successful treatments to our patients.
Thank you so much for sharing that. Do you have any other final thoughts you'd like to share before we wrap up?
I really look at RFA as a global phenomenon, and it's just interesting that the U.S. has been a little late to the game, but now finally we're here. And so I think that's really exciting. I do have the names of my colleagues in Manila if you need some Philippine referrals.
Yes, absolutely. If you want to look for those in the video description, I'll be sure to put those there for any of the viewers who are in the Philippines. And for those in South Africa, stay tuned because I think you said they were working on that. So very exciting. Well, thank you so much for joining me today. It's been a pleasure talking with you.
Thank you for the invitation. It's been an honor.
That wraps up today's episode. If you found this valuable, please like, subscribe, and share it with someone who might benefit. You can find links to everything we discussed in the show notes below. Find a physician, discover treatment options, and join our patient community at saveyourthyroid.org. To stay up to date on new episodes, resources, and expert insights, be sure to subscribe to my mailing list at saveyourthyroidwithjen.com. It's the best way to stay connected and informed. There you can also find all podcast episodes and book a 1-hour patient navigation consult for personalized guidance on your next steps. As always, please remember this podcast is for informational purposes only and is not a substitute for professional medical advice. No endorsement is given or implied for any specific product, treatment, or physician mentioned. As always, consult with a qualified healthcare professional for your individual needs. Thanks for listening, and I'll see you next time.